Hi, I'm Dr. James C. Wittig. I'm an orthopedic oncologist and sarcoma surgeon. Today we're going to talk about the radiographic evaluation of musculoskeletal tumors. For more information about musculoskeletal tumors, you can visit my website at www.tumorsurgery.org. These are the following staging studies that are important for evaluating bone tumors and sarcomas: plain radiographs, MRI, CAT scan, chest CT, and bone scan. Plain radiographs are very useful in the differential diagnosis of bone tumors. In terms of evaluating soft tissue tumors, they're useful for detecting mineralization, namely calcification or ossification within tumors, and also if there's any underlying bony erosion from an adjacent soft tissue mass. MRIs are most useful for evaluating intraosseous and extraosseous extent of tumors, which is important for surgical planning. They're rarely useful in the differential diagnosis, but sometimes they are. A CAT scan is useful for evaluating or detecting very subtle calcifications or endosteal erosions or periosteal erosions from adjacent soft tissue mass. Chest CT is useful for evaluating for lung metastases. Sarcomas metastasize to the lungs and to other bones. These are the two most common sites of metastases, and a chest CT is useful in the workup of a bone sarcoma or any type of soft tissue sarcoma. Bone scans are useful for detecting bony metastases. They are useful also for identifying intraosseous extension of bone tumors and the length of the bone tumor to see if it correlates with the MRI. But the most important or the most value in a bone scan is for determining the presence of bony metastases or skip metastases. Plain radiographs are used to evaluate the rate of tumor growth, the tumor interaction with the surrounding non-neoplastic tissue, as well as the bone interaction or the bone reaction against the actual tumor. And it's also useful for evaluating the internal composition of the tumor. The rate of growth can be determined based on how the tumor appears on the radiograph. In other words, is the tumor very well circumscribed, indicating that it is slowly growing, where you can make out the border between the tumor and the normal bone, or is the border between the tumor and normal bone blurred and indistinct, indicating potentially a fast-growing or malignant type of tumor? MRI is useful for visualizing the entire bone in the adjacent joint. It's useful for demonstrating skip metastases across an adjacent joint. It's the best test for intraosseous extension and soft tissue extension. It's useful for identifying skip metastases, which is an intraosseous metastasis separate from a primary tumor or primary malignant tumor or primary sarcoma, like an osteosarcoma. So, for instance, having an osteosarcoma develop in the distal femur, but having a skip metastasis in the proximal femur. It's useful for determining the proximity of the tumor to the neurovascular structures. It's occasionally helpful in the diagnosis of a bone or soft tissue tumor, but rarely helpful in the differential. These are the MRI signal intensities of various tissues. Typically, standard MRIs call for both T1 weighted and T2 weighted images. And these are their various tissues. A hematoma is high signal on T1 and high on T2. Fat and fatty marrow is high on T1 and intermediate on T2, unless the T2 is fat suppressed. If it's fat suppressed, fat will be low signal on the T2. Muscle, nerves, and hyaline cartilage are intermediate on T1 and intermediate on T2. Cortical bone, tendons, ligaments, fibrocartilage, scar tissue, air, calcifications, and also hemosiderin deposition, such as that occurs in pigmented villonodular synovitis, are low signal on T1 and low on T2. This is very helpful sometimes in differential diagnosis. Hyaline cartilage is intermediate on T1 and T2. Red bone marrow or hematopoietic bone marrow is low signal on T1 and intermediate to high signal on T2. Fluid is intermediate signal on T1 and high signal on T2. In general, tumors are intermediate to low signal on T1 and high signal on T2. Lipomas are high signal on T1 and intermediate signal on T2 unless they're fat suppressed, in which case they'll be low signal. Hemangiomas are intermediate signal on T1 and high signal on T2 because of the blood flow. You might also be able to identify areas of fat within a hemangioma on the T1 and T2 weighted images. CAT scans are good for evaluating cortical details in destruction, subtle cortical erosions that might not be so well detected on an X-ray, either the endosteal erosion from an intraosseous tumor or periosteal erosion from an adjacent soft tissue tumor, and they're useful for detecting subtle calcifications and ossification or visible matrix mineralization. The next 3 slides demonstrates how plain radiographs should be utilized to evaluate a bone tumor. There are specific characteristics that should be identified on plain radiographs that aid in the differential diagnosis of a bone tumor. On plain radiographs, you should identify what bone is involved. There are certain tumors that occur in certain bones, or occur more commonly in one bone than another bone. Is the involved bone normal, or is it abnormal, such as is it affected by a metabolic disease, such as hyperparathyroidism, where you may have a brown tumor of hyperparathyroidism? Is the bone osteoporotic? Are there other metabolic abnormalities in the bone that are reflected in the bone? What part of the bone is involved in both the longitudinal plane and the transverse plane? So is the epiphysis, the metaphysis, or the diaphysis involved by the tumor? And there are certain tumors that have a predilection for the epiphysis, certain tumors for the metaphysis, and certain tumors for the diaphysis. Is there an open or closed growth plate? As certain tumors occur more commonly in a skeletally immature person versus a skeletally mature person. Where is the epicenter of the tumor? Is it in the central within the bone, in the medullary canal? Is it eccentric? Is it cortically based, or is it periosteally based? And what's the tumor contour and the zone of transition between the tumor and the host bone? In other words, is there a sharp zone of transition between the tumor and adjacent normal bone, meaning a sharp cutoff where you can determine where the tumor stops and normal bone begins, or or is this imperceptible, where you cannot determine where the tumor stops and the bone begins? If you can pick out the borders of the tumor, then usually that tumor is benign. If it's imperceptible or blends imperceptibly with the adjacent bone, then that suggests that this is a malignant process. Is there mineralized matrix? In other words, is the tumor or the cells of the tumor producing a matrix that's visible on an X-ray? This would come in the form of producing calcifications or ossification, which may help you place it in a particular category. Is there cortical destruction? Is there a periosteal reaction, and what type? So for instance, both benign and malignant tumors can penetrate the cortex and form a soft tissue mass. A benign tumor usually has a eggshell rim of calcification around the perimeter of the soft tissue mass, indicating that the periosteum is intact. Technically, this is a periosteal reaction. And there are various different types of periosteal reactions, namely your interrupted and your uninterrupted or your continuous periosteal reactions. Continuous meaning that they tend to surround the entire tumor, usually indicate a benign process, whereas your interrupted periosteal reactions, such as your Codman's triangle, hair on end, lamellated or onion skinning, and your sunburst reactions tend to signify a malignant process or a more aggressive process. Is there involvement of the joint space? Is the tumor multifocal? Is a tumor uniform in appearance, or does it have different components? Is it biphasic, such as a dedifferentiated chondrosarcoma, where you can see a low-grade type of cartilage tumor next to a high-grade aggressive appearing lesion or continuous with an aggressive appearing area that signifies the dedifferentiated or the high-grade sarcoma component. So to summarize, for radiographic evaluation, you want to evaluate the bone that's involved and the position in the bone in both the longitudinal and transverse plane. The pattern of bone destruction, is it geographic, permeative, or Mothian? The margin around the lesion, is it well circumscribed with a thick sclerotic margin or a thin line around it? Is the presence of any visible tumor matrix, such as calcification or ossification, along with the lines in the line with visible tumor matrix? Is there internal trabeculations? There is a differential for internal trabeculations. Internal trabeculations are thickened reactive trabeculae within a tumor. And there are various tumors that may regularly demonstrate this. I used the mnemonic D. Chang, named after a resident of mine in the past, David Chang, who's a prominent spine surgeon now. His D stands for desmoplastic fibroma, C for chondromyxofibroma, H for hemangioma, A for aneurysmal bone cyst, N for non-ossifying fibroma, and G for giant cell tumor. Is there cortical erosion, penetration, or cortical expansion? Is there extension into the soft tissue? And if so, is that soft tissue component surrounded by an eggshell rim of calcification? And is there a periosteal response, whether continuous, and is it continuous or inter-appearing? This is just showing you schematically the things that you need to evaluate on x-rays. The zone of transition of the tumor, if there are calcifications, if it's a geographic pattern of bone destruction, if there's a solid periosteal reaction. Is a bone destruction permeative, where you can't make out the borders like you can on a geographic pattern of bone destruction? Example of an interrupted periosteal reaction, where you have sunburst reaction. Does it occur in the epiphysis, the metaphysis, or the diaphysis? Is there a soft tissue mass, and is it surrounded with a eggshell rim of calcification? Is there any evidence of multiplicity or multicentric disease? Okay, we're going to go through the different patterns of bone destruction. I lump permeative and Mothian into a single category because usually they coexist with each other and they're indicative of a malignant process. A geographic lesion, which is fairly well circumscribed, or where you can make out the borders of the lesion, is usually indicative of a benign process. This is showing you schematically what a geographic pattern of bone destruction looks like. It's very well circumscribed, and you can usually make out the border between the tumor and the normal bone. It's a sharp zone of transition, or sharp cutoff between the tumor and the normal bone. Mothian or permeative patterns tend to coexist. This is an example of a Mothian pattern where you can see these areas of bony lysis separated by what appears to be normal or permeated bone. Usually the bone in between these areas of lysis is occupied by tumor. And this is a permeative lesion which can blend imperceptibly with the bone, and you cannot make out the borders of this lesion. Both of these are indicative of a malignant or an aggressive process. Usually a geographic lesion is indicative of a benign process. Here's an example of geographic bone destruction, or a benign neoplasm. This is a giant cell tumor of the distal radius. You can see that it's very well circumscribed, and there's a narrow zone of transition between the tumor and the normal bone. You can make out the border of this tumor, in other words, and you always have to look at where the tumor is juxtaposed to normal bone. This indicates a slow-growing tumor, meaning slow-growing compared to a malignant tumor. There's clear delineated borders. You may or may not have a sclerotic margin around it. Sometimes the tumor is growing rapidly enough where the bone does not have a chance to react against it, and you do not get much of a sclerotic margin around it. And sometimes it's growing very slowly, and the bone has time to react against it and creates a very thick sclerotic margin around it. Obviously, the less sclerosis around it, or the less rim or sclerotic rim around it, means it's more aggressive or faster growing. Usually, these tumors are benign. There are some exceptions. Myeloma can have a geographic appearance, metastases, and osteomyelitis, particularly fungal or tuberculous osteomyelitis, granulomatous type of osteomyelitis, can look very geographic in nature. And we're going to go through various examples, but what you want to look at with these different examples of geographic bone destruction is the sharp zone of transition between the tumor and normal bone. This is an aneurysmal bone cyst. Sharp zone of transition. This is a giant cell tumor. You can see this is a tumor that's developed in the metaphysis, extends into the epiphysis, it's extended into the soft tissues, and there's a geographic pattern of bone destruction, or a sharp zone of transition between the tumor and adjacent bone. You can tend to see internal trabeculations in here, and there's an eggshell rim of calcification around the soft tissue component, indicating this is likely benign. This is the CAT scan of the same tumor. If you had difficulty seeing it on the X-ray, CAT scans and MRIs can be useful. You see a narrow zone of transition between the tumor and normal bone, and you see this expanded area of the cortex where the tumor has destroyed the cortex, extended into the soft tissue, but the soft tissue component is surrounded by an eggshell rim of calcification, indicating that it's benign. But the important point here is that this sharp zone of transition, you can make out the border. That's a geographic type of tumor. Here's an MRI correlate with it. This MRI is notable for fluid levels. It's important to remember that some giant cell tumors can undergo cystic change, where there's bleeding and hemorrhage into the tumor because it grows rapidly and cuts off its own blood supply. The fluid, or the hemosiderin products, or the blood products, settle to the gravity-dependent portion of the cystic cavity, or the lesion. So this patient's on their back getting an MRI, and here you can see the fluid levels with the sediment from the blood products settling to the gravity-dependent area and forming these fluid levels. These are also called secondary aneurysmal bone cyst changes. And secondary aneurysmal bone cyst changes can occur in a number of lesions, particularly giant cell tumors, non-ossifying fibromas, the chondroblastomas, osteoblastomas can all undergo secondary ABC change. Here's a lesion in the epiphysis. It's a little bit difficult to discern the lesion based on this X-ray. However, it does appear to be fairly well circumscribed. There's a sharp zone of transition between the tumor and the adjacent bone. There is a differential diagnosis of epiphyseal type lesions, and that includes chondroblastoma, clear cell chondrosarcoma, eosinophilic granuloma, osteoblastoma, osteoid osteoma, infection, intraosseous ganglion, eosinophilic granuloma, Mets, myeloma, and lymphoma. These are all possibilities within the epiphysis. Giant cell tumors usually arise in the metaphysis and spread into the epiphysis, and usually do not occur in a skeletally immature patient. If you had difficulty discerning that this is geographic pattern of bone destruction, then you might want to look at a CAT scan and or an MRI. This is showing you the CAT scan correlate of that lesion, where the lesion is extremely well circumscribed. You can see the junction of the tumor with normal bone, and it has grown into the tibial eminence and expanded the tibial eminence. The soft tissue component of it is covered with an eggshell rim of calcification. And here's the MRI again, showing a very well circumscribed lesion where you can make out the borders of the lesion with normal bone, indicating a benign tumor. This was a chondroblastoma. There's a lesion here in the proximal humerus. It's difficult to discern on this view. This is the axillary view where you can make out the borders of the lesion. You can see where there's a sharp zone of transition indicated by the arrows between the tumor and normal bone. Here's an MRI of the same lesion. This is a very irritating lesion. It's causing an effusion in the adjacent joint. It's very well circumscribed. There's a narrow zone of transition between the tumor and adjacent bone. This is a lesion of the distal tibia. If you look here at the junction of the tumor with the normal bone, there's a sharp zone of transition. The tumor has also expanded the bone. It's given it a wider contour. What has really happened is the tumor has been growing inside the bone, gradually eroding the endosteal surface of the bone. While it's eroding the endosteal surface of the bone, the bone is laying, or the periosteum is laying down new bone on the outside, which gives us an expanded bony contour. This is the lateral, again showing the sharp zone of transition between the tumor and normal bone, indicating that this is benign. Here's an MRI of that tumor. This was an aneurysmal bone cyst. And important to note on aneurysmal bone cysts, just like with secondary ABCs, you can have these fluid levels. Remember, this person is laying on their back for the MRI, and the sediment from the actual blood or the cystic cavities within the tumor settles to the gravity-dependent area and produces these fluid levels, where there's these darker areas that are in the more gravity-dependent region of the cystic cavities. This is very much consistent with an aneurysmal bone cyst. If you weren't able to see the geographic nature of the tumor on the X-rays, an MRI can be useful where you can see a narrow zone of transition between the tumor and the adjacent normal bone. Here's an example of another giant cell tumor of the distal femur, sharp zone of transition with a slight sclerotic margin around the tumor at its junction with the medullary canal. The lateral, the same tumor, again noting the geographic nature of the tumor. You can pick out the borders of the tumor where the tumor stops and normal bone begins. And an MRI correlate, in case you could not really adequately see it, on the X-rays, MRI can be useful. Here's a CAT scan, again showing the same lesion, the giant cell tumor. Very well circumscribed, narrow zone of transition, no mineralization in the mass, and an internal trabeculation. And again, when you see internal trabeculations, you have to think along the differential diagnosis of desmoplastic fibroma, giant cell tumor, chondromyxofibroma, hemangioma, aneurysmal bone cysts, and non-ossifying fibroma. When talking about geographic bone destruction, there are different types of margins that you could have around the lesion. And there are generally three types of margins that have been noted by radiologists, 1A, 1B, and 1C. And these indicate the activity within the tumor. The tumor could be sitting there doing nothing or growing extremely slowly, or it could be growing rather rapidly and aggressively and destroying the bone. We call these types of margins type 1A, type 1B, and 1C. They're important to note because they may help you determine the type of treatment for the patient. So a 1A margin consists of a thick, complete sclerotic margin around the tumor. This indicates an indolent lesion or extremely slow growing, such as a non-ossifying fibroma. 1B is a thin and incomplete margin, which indicates an actively growing lesion, and 1C is where there's no sclerotic margin, it's more aggressive or more rapidly growing, than an active lesion. Your 1A types of tumors you may be able to treat with a simple curettage or may just observe them. You would curette them and bone graft them, whereas your 1B and 1C have a tendency to recur. You may add an adjuvant treatment like cryosurgery, or you may instead of bone grafting it, choose to put cement in the bone to fix the bone as well as and stabilize it early, as well as be able to detect recurrences early, since the white cement contrasts nicely against the actual tumor. Okay, this is showing you our examples of a 1A margin, 1B, and 1C. And as you go from 1A to 1C, the tumor becomes more rapidly growing and more aggressive. 1A has a nice thick sclerotic margin around it. An example would be a non-ossifying fibroma. 1B would be an active giant cell tumor, and 1C would be a more aggressive giant cell tumor. Or maybe 1B may be more like a chondroblastoma, and 1C more consistent with more rapidly growing tumor like a giant cell tumor. This is just showing you schematically. Benign tumors have well-defined borders and a narrow zone of transition, where your malignant tumors may have ill-defined borders and more of a wide zone of transition. One A margin, which surrounds a complete lesion, thick and sclerotic. Again, a 1A margin that surrounds a complete lesion, and it's thick and sclerotic, non-ossifying fibroma. 1B margin with a giant cell tumor, very subtle sclerosis around the lesion. Another 1B margin, subtle sclerosis, deficient in some areas and more heavily mineralized in other areas. Again, a 1B margin where there's some sclerotic areas and some areas with not as much sclerosis. This is an MRI of the same lesion. You can see down here where there's more sclerosis around the lesion, and up here maybe this is a more active area. There's less sclerosis. 1C margin where you do not see a sclerotic margin around this lesion at all. Another 1C margin. This is a giant cell tumor. You can see it's destroyed the entire distal radius. There's internal trabeculations. But you look here at the junction of the tumor with normal bone, and you see a sharp zone of transition. You can see where that tumor ends and normal bone begins. Again, a 1C margin. You do not see a sclerotic margin around this lesion. It's also an example of a giant cell tumor. 1B/1C margin. A 1C margin around a giant cell tumor. Again, a 1C margin around a giant cell tumor on a CT, but very well circumscribed and geographic. Okay, now we're going to turn to discussing the types of bony destruction that correlate more with a malignancy, such as a morphine or permanent bone destruction. Often both of them coexist, and they're both indicative of more aggressive bone destruction. There's less well-defined margins. It's difficult for you to make out the borders of the tumor, or where the tumor ends and normal bone begins. There's larger zone of transition from normal to abnormal bone. You can in a Mothian pattern of bone destruction, you see multiple punched-out holes, usually separated from each other by tumor tissue that appears permeative in nature. And it's indicative of a malignant type of bone tumor, osteomyelitis, or rarely eosinophil granuloma, which is a benign condition, can have a similar appearance. But this is a classic example of Mothian bone destruction. You can see these areas of lysis separated by what it appears to be bone that's permeated by a lesion. Here's another example, two areas of lysis separated from each other from a distance with area of permeation in between. Here's an example of a permeative pattern of bone destruction. This is the fibula. There's a lesion in the fibula. You cannot make out the borders of the lesion or where the tumor ends and normal bone begins. The tumor has grown outside the cortex and has destroyed the periosteum in this area, but it's elevated the periosteum at the perimeter to form these Codman triangles. This is a very aggressive appearing lesion, and you can't make out it. The important thing is you can't make out the borders of this tumor. It's permeating through the bone. It's growing rapidly. And this is indicative of malignant bone tumors like a Ewing sarcoma, an osteosarcoma, although osteomyelitis and severe osteoporosis can sometimes have an appearance similar to a permeative type of sarcoma. Here's an example of a lymphoma causing permeative pattern of bone destruction of the superior pubic ramus. You can't make out the borders of the tumor. Here's a permeative lesion of the proximal femur. Again, you can't make out the borders of the lesion, and it's causing a reactive sclerosis in the bone. It's a higher power view. Here's an osteosarcoma of the distal femur. You can barely make out the lesion. It blends imperceptibly with the surrounding bone. It is extending into the soft tissues. It's elevating the periosteum at the perimeter, and it's forming bone in the soft tissues. Again, the lesion is permeative in nature. You can't make out the borders of the lesion. And here on the lateral view of this osteosarcoma, you can see where it's spread into the soft tissues, and you see some bony production by the tumor in the soft tissues, these fluffy cloud-like densities. Here's a lymphoma of the proximal femur, again a permeative pattern of bone destruction. Here's an osteosarcoma of the proximal femur with a permeative pattern of bone destruction. Again, you can't make out the borders of the tumor. Here's an MRI showing you the same tumor. There's a permeative lesion in the humerus, which has resulted in a pathological fracture. The lesion blends imperceptibly with the bone, both proximal and distal to the area of the fracture. It's difficult to tell where this lesion begins and ends. But you look at the MRI, and you can see that the tumor extends from the proximal aspect of the humerus all the way down to the distal aspect, very permeative in nature. So MRI is very useful for determining the intraosseous extent of these permeative types of tumors. Here's a very good example of a proximal tibia lymphoma. You can barely make out the lesion. It's blending imperceptibly with the bone. In this case, it was very important to do a physical examination of the patient because she had a very large soft tissue mass around this, and it was difficult to see with the contrast on the PAC system that there was truly a lesion in this bone. This is the lateral view. You can see some little areas of moth-eaten lysis in the proximal tibia. Here's an MRI showing you diffuse permeation of tumor throughout the entire proximal tibia, which was extremely difficult to discern on the plain radiographs. Here's a CAT scan of the same bone showing you permeation of the tumor with these subtle moth-eaten areas. Here's a permeative osteosarcoma of the humeral shaft. Again, you can't make out the borders of the tumor. Here's the MRI correlate showing you the extent of the tumor. We're going to talk a little bit about visible tumor matrix. So Once you've looked at the tumor and you've determined that the tumor is either geographic, permeative, or Mothian, you want to look inside the tumor and see if the tumor is making any sort of matrix that can be visualized on an X-ray. And the type of matrices that can often be visualized on an X-ray are those that calcify or ossify. And calcifications are usually consistent with a cartilage type of tumor, or a tumor that's producing cartilage, and ossification usually with a tumor that's producing bone itself. Are different types of, so visible tumor matrix, usually when you're speaking about that, you're usually talking about some form of mineralization that's detectable in either calcification or ossification. Calcification comes in the form of stippled calcifications, flocculent calcifications, and ring and arcs, whereas ossification is solid, cloud-like, or ivory-like. You need to differentiate this type of mineralization from calcification due to dead or necrotic tissue, fracture callus, pathologic fracture, or a sclerotic response of non-neoplastic bone to an adjacent tumor deposit. Once you've decided if a tumor is benign or malignant, and you've decided if it has calcifications, so for instance, say the tumor was permeative and demonstrated ring and arc calcifications and it had a soft tissue mass, you'd say this is a malignant appearing tumor with calcifications, very suggestive of a chondrosarcoma. Or on the other hand, if the tumor is producing bone and it appears to be permeative in nature and malignant bone-producing tumor would be called an osteosarcoma. So this is how we narrow down our differential diagnosis. These are your different types of ossification and calcifications. This is just showing you schematically what they can appear like. Your solid, your ivory-like, and your cloud-like are more consistent with ossification, where you get this dense marble-like ossification or white area in the bone. It can appear more like this with some areas which look like conversion canals or more cloud-like. And you can have flocculent, stippled, or ring and arc type calcifications. The ring and arc type calcifications occur because cartilage tends to grow in lobules, and you get endochondral ossification around the perimeter of a lobule. If you get it around the entire perimeter and it calcifies around the entire perimeter, it shows up as a ring or a circle or a donut on an X-ray. If it calcifies around a portion of the lobule, then you end up with an arc, or a half a circle, or a portion of a circle. So calcification occurs in ring and arcs, flocculent, or fleck-like. It usually indicates a cartilage-type tumor. Enchondromas and chondrosarcomas usually almost routinely demonstrate ring and arc calcifications. Chondroblastomas and chondromyxofibromas demonstrate calcifications in about 30% of cases, and you may require a CAT scan to detect these calcifications. Likewise, an osteochondroma will usually demonstrate some calcifications in its cartilaginous cap. Cartilage grows in a lobular manner or in a ball-like manner. Calcification occurs around the periphery of these lobules. If the calcification occurs completely around the periphery, circumference, it forms a circle or a ring of calcification that is detectable on the X-ray. If the calcification occurs only partially around the lobule, it forms only part of a circle or an arc that is detectable on the X-ray. Here's your cartilage or visible cartilage matrix. This is what stippled looks like. This is what flocculent looks a little bit more amorphous and a little bit larger areas of calcification. And this is rings and arcs. Often there's a blend of all three of these in a tumor. On X-ray and CAT scan, you can see the little circles or the ring and arc calcifications, little donut sign or an O sign. Same thing in the CAT scan. You see circles, half circles, semicircles of this calcified tumor, indicative of a cartilage or hyaline cartilage tumor. This would be either an Enchondroma or a low-grade Chondrosarcoma. And these are various examples. Here's an Enchondroma with ring and arc calcifications. Here's a Chondrosarcoma in the hand. Hyaline cartilage tumors should always remain intraosseous. If they ever extend extraosseously, they are considered a malignancy. Here are various stippled, flocculent, and ring and arc calcifications that would place us in the category of a cartilage tumor. One would think that this is a malignant cartilage tumor based on the fact that it's extending extraosseously. And this was a chondrosarcoma. This is an intraosseous lipoma where probably some of the fat has undergone necrosis and has resulted in calcium deposition. This is very discernible on the CAT scan. And here's another CAT scan image showing you the calcium deposition. This is a chondrosarcoma of the proximal humerus, and you'll see calcifications in a ring and arc-like manner in the proximal humerus. There's a pathological fracture here also. It's a closer view where you can look at the little circles or the little rings and the arcs, putting this into likely a cartilaginous category. Again, a different internal rotation view where you can see some of the mineralization a little bit better, where you can make out the rings and the arcs throughout the proximal humerus. And here's a CAT scan showing you an extraosseous mass. You should not have an extraosseous mass with a benign cartilage tumor. So this would be indicative of a malignancy, and that you put everything together, being that it's likely a cartilage tumor with the ring and arc calcifications and with an extraosseous mass, that this is a malignant cartilage tumor or a chondrosarcoma. This is an osteochondroma. It's grown from the proximal fibula. You can tell this is an osteochondroma because there is corticomedullary continuity. You can see here the cortex extending into the osteochondroma with the medullary canal. This is the cartilaginous cap, and you can see here areas of mineralization, the calcifications that are occurring in stippled and in a flocculent manner with rings and arcs. Very indicative of a cartilage tumor or hyaline cartilage tumor, and put that together with the corticomedullary continuity, and very suggestive of an osteochondroma. Close-up view, you can see the stippled and flocculent calcifications and a few ring and arc calcifications in the cartilaginous cap. Another osteochondroma, you can demonstrate the corticomedullary continuity. This one is heavily calcified, and you can see the little rings and arcs throughout the cartilaginous cap. Here's a closer view. This is a biphasic tumor. This is a dedifferentiated chondrosarcoma. You can see here where there is a low-grade appearing cartilage tumor juxtaposed to a more aggressive lytic tumor. This more aggressive lytic tumor is a high-grade spindle cell sarcoma, namely either an MFH, an osteosarcoma, or a fibrosarcoma. And here you can tell that this is the cartilaginous component because of the ring and arc calcifications and stippled areas of calcification and flocculent areas throughout it. Showing you the x-ray, showing you the calcifications and the lytic destruction by the dedifferentiated component. Again, closer view of the areas of mineralization, the ring and arc calcifications, and the flocculent type of calcifications juxtaposed to the area of lysis. This is another example of ring and arc calcifications. It's important to just be able to differentiate the calcification from the ossification, which is going to help you categorize these tumors into different their different subsets or their different categories according to the type of matrix that they produce. Again, a high power view. You can see a circle here, some flocculent area here, a circle here, a circle there. This is an example of an enchondroma in the femur, or possibly a low-grade chondrosarcoma, but you can place this in the category of a hyaline cartilage tumor because of the ring and arc calcifications. This is a lateral view and a CAT scan of the lesion. There's a CAT scan of an enchondroma or a low-grade chondrosarcoma of the femur, where you can really make out nicely the little rings associated with the calcification around the individual lobules of cartilaginous tissue. Ossification, on the other hand, is cloud-like, fluffy, and marble-like. And if you can identify ossification, the differential would be an osteosarcoma, a parosteal osteosarcoma, an osteoblastoma, and osteoma. Osteoblastomas rarely mineralize. Approximately 30% of them will mineralize on an X-ray or a CAT scan. The mineralization may be so subtle that it will require a CAT scan to actually identify it. Here's a good example of ossification. You can see a fluffy, cloud-like white density in the soft tissues around this elbow. This is what ossification looks like. It's fluffy and cloud-like. Here's a lateral X-ray showing you the fluffy, cloud-like ossification around the elbow. And you can see the difference between this and what is termed calcification. This is an example of an osteosarcoma, and you can see the fluffy, cloud-like mineralization within the tumor, and also in the soft tissue component of the tumor. This is the CAT scan showing you the fluffy, cloud-like ossification in the tumor. Lateral X-ray showing you the soft tissue mass with the fluffy, cloud-like ossification. Again, helping you to place this in the category of an osteosarcoma based on looking at the radiographs. Here's an osteosarcoma of the humerus with fluffy cloud-like ossification in the soft tissue component. Osteosarcomas rarely occur in the diaphysis. Only about 10% of them occur in the diaphysis. However, looking at this X-ray, you would say this is a permeative lesion, which would mean likely malignant, and there's a soft tissue mass. And in the soft tissue mass is producing bone. There is ossification. So you should, despite this being a rare site, be able to place this in a category of likely being an osteosarcoma. This is just showing you a close-up view of the soft tissue mass with the mineralization or the ossification within it. And a CAT scan, again, showing you the ossification in the soft tissue component. This is a periosteal osteosarcoma. You can see where the lesion on the surface of the bone here is solid and marble-like, very heavily mineralized. This is the lateral. Again, you see fluffy, cloud-like, marble-like density overlying the tibia. This is a CAT scan showing you the surface lesion of the bone with the lesion producing this marble-like density. It's a conventional osteosarcoma, which is a permeative lesion, and you can see the fluffy cloud-like area in the soft tissue component and the subtle sclerosis in the medullary canal, which is indicative of ossification. Lateral X-ray, where you can see the tumor has protruded through the posterior aspect of the femur, and you can see the fluffy cloud-like density in the posterior soft tissues, indicative of an osteosarcoma. Another type of conventional intramedullary osteosarcoma where the ossification is very marble-like in the center of the medullary canal of the femur. And a lateral x-ray of the same, showing you the dense marble-like ossification within the femur. This is a very worrisome finding. One should be highly suspicious of an osteosarcoma and should not dismiss this as a bone island. It's another example of an osteosarcoma of the distal femur. You can see here a permeative lesion which is producing bone, this fluffy cloud-like substance in the soft tissues and in the medullary canal, and it's elevated the periosteum at the periphery, producing Codman triangles. This is a lateral of that osteosarcoma, and again, notice the fluffy cloud-like density in the soft tissue component of the tumor. CAT scan of the same, showing you the fluffy cloud-like densities in the soft tissue component. Here's a paraosteal osteosarcoma, which arises from the surface of the bone, and you can see this marble-like density on the surface of the bone. It's white, marble-like, very dense. Here's a CAT scan, and you can see it almost looks like a cauliflower on the surface of the bone. There's no corticomedullary continuity. There's no medullary cavity of this lesion, so it's not an osteochondroma, and it's dense, marble-like. It is not flocculent or stippled or ring and arc-like. Here's a paraosteal osteosarcoma of the posterior distal femur. Again, it almost looks like a cauliflower stuck to the posterior surface of the bone. The cortex is intact, and it's fluffy and cloud-like or marble-like off the posterior aspect of the femur. Very worrisome for a paraosteal osteosarcoma. Here's a CAT scan of the same, showing you that it's a surface lesion of bone. The cortex appears to be intact. There may be some slight back growth of it through the cortex. However, you see this white, dense mass on the surface of the bone. It appears fluffy and cloud-like, indicative of ossification. When discussing visible matrix, it's important to discuss internal trabeculations, because these can also be identified within tumors. And internal trabeculations represent residual trabeculae which have reacted to the tumor. There's new bone formation due to adjacent tumor, and it's somewhat reactive in nature. I've mentioned in the previous, earlier in this talk, that the differential is named after a resident of mine, David Chang. We use his first initial, D. Chang, for desmoplastic fibroma, chondromyxofibroma, hemangioma, aneurysmal bone cyst, non-ossifying fibroma, and giant cell tumor. This is a giant cell tumor of the distal radius. You can see a geographic pattern of bone destruction. There's a sharp zone of transition between the tumor and the adjacent bone, and then there's these thickened trabeculations throughout the lesion. If you saw these trabeculations, you would go down your differential in this location. The distal radius is the third most common site of origin for a giant cell. Here's a giant cell tumor with internal trabeculations. It's destroyed the entire distal radius. This is a desmoplastic fibroma, where they often have extremely thickened internal trabeculations. The fibrous tumors are usually central within the medullary canal of the bone that it arises from. This is a chondromyxofibroma, where the medullary border of the lesion is very indolent appearing. That's very typical. There's a couple internal trabeculations, and then the exterior or the external surface is usually very expanded and more aggressive looking. This is a non-ossifying fibroma. There is a very thick cortical thick sclerotic margin around the lesion, internal trabeculations, and it arises from the cortex. This is a hemangioma where you can see that the internal trabeculations are thickened. This is a vertebral body hemangioma. And finally, this is your aneurysmal bone cyst. It is an expansile lesion in the distal tibia. This is a skeletally immature patient. There are some internal trabeculations here and over here. It has a geographic pattern of bone destruction, but again, this is an example of your ABC. If you had an MRI, you would be looking for fluid levels. Okay. We're going to turn our attention now to discussing periosteal reactions. There are continuous types of periosteal reactions and interrupted types of periosteal reactions. The interrupted periosteal reactions are the more worrisome type of reactions, which are usually indicative of malignancies, although also can be indicative of infections. Your continuous periosteal reactions are more indicative of benign conditions, or infections or Brody's abscesses. The continuous periosteal reactions, meaning that the periosteal reaction is never broken. It exists intact around the entire lesion or around the soft tissue component of the lesion. It may appear just as subtle cortical thickenings, such as in this area. It may be undulated or wavy in nature. It may exist around a benign tumor, which is geographic in nature and is broken into the soft tissues, but has an intact layer of periosteum around the perimeter, where in the area around the most expanded part of the tumor is very thin and looks like an eggshell. Then we have our interrupted periosteal reactions. In this sunburst type and the perpendicular or the hair-on-end type, or also called velvet type of periosteal reaction, it indicates a malignancy which has grown very rapidly and spread out through the haversion systems. And in between the individual haversion systems, you get a periosteal reaction, which is longitudinally oriented perpendicularly to the bone. There's a lamellated or an onion skin type of periosteal reaction, which indicates some sort of cyclical growth of the tumor. And then there's a Codman's triangle, where the tumor can grow into the soft tissues and elevates the periosteum at the perimeter of the tumor and destroys it directly overlying the soft tissue mass of the tumor. You can see the Codman's triangle right in this location. These are very worrisome when you see them on a radiograph, so it's very important to be able to detect them. They can be very or extremely subtle. So your benign appearing periosteal reaction can look like a buttressing pattern, a single layer, a single lamellar, cortical thickening, or bony expansion. Endosteal erosion leads to a periosteal proliferation, can be the same or a decreased thickness compared to a normal cortex. And buttressing refers to the interface between normal and expanded cortex that is filled in with bone. So it almost looks like the cortex is just thickened in one particular location. Examples may be an osteoid osteoma, a Brody's abscess, and we'll show you an example. Here's an example of buttressing. You can see here where the cortex looks almost just thickened in this one area, although you see this tiny little area of lysis in the center of the periosteal reaction, which is likely indicative of an osteoid osteoma. With regards to periosteal reactions in malignant tumors grow rapidly, and the rapid tumor growth may lead to single or multiple concentric layers. Often these concentric layers are interrupted in some way, and again, like I said before, you can get onion skinning, Codman's triangle, sunburst reaction, or hair-on-end reaction. This is your onion skin appearance. You can see multiple concentric layers overlying a permeative lesion. This is also an example of an onion skin reaction overlying a lesion in the bone in a skeletally immature patient. This was actually an eosinophilic granuloma. Interestingly, eosinophilic granuloma can occur in any location within a bone and can be geographic, permeative, or mouthy, and be associated with any type of periosteal reaction. There can be a Codman's triangle. You can see in this x-ray a very subtle Codman's triangle. In this depiction over here, you can see the tumor growing out in one area and elevating the periosteum at the periphery, and essentially that's what happened. This is a very subtle finding. Here's an example of a radiograph of a Codman's triangle adjacent to an osteosarcoma that grew into the soft tissues. You can see a little bit of ossification here in the soft tissues from the soft tissue component of the tumor. Here's an example of a Codman's triangle, an extension of the tumor into the soft tissues with fluffy cloud-like ossification. This is the CAT scan of the Codman's triangle. This is a sunburst pattern where there's perpendicular striations of new bone formation that come out from an angle from the bone. So you have a tumor that's grown very rapidly. It has grown so rapidly that it's penetrated through the Haversian canals, and in between the individual Haversian canals, you have this periosteal new bone that's formed and comes out in a striated manner perpendicular to the bone. This is a hair-on-end appearance where the periosteal reaction is more perpendicular as opposed to an angle. Again, they're indicative of rapidly growing tumors, very worrisome for malignancies. So to summarize or reiterate, our benign tumors demonstrate a geographic pattern of bone destruction, have a unified, uninterrupted may be associated with unified, uninterrupted periosteal reaction, may expand the bone or cause cortical thickening, and have a well-defined border, and may have a sclerotic rim around them. Malignancies demonstrate an ill-defined border. They may be permeative or Mothian. They can extend into the soft tissues. When they extend into the soft tissues, usually they destroy the periosteum around the perimeter of the soft tissue component. They may elevate the periosteum at the perimeter or between individual Haversian canals, and they break or they cause an interrupted periosteal reaction, such as a Codman's triangle, hair on end, or sunburst reaction, or even a onion skin reaction. So, a little word about soft tissue masses. Soft tissue masses can occur with primary malignant bone tumors, benign aggressive bone tumors, metastases, and with osteomyelitis. With osteomyelitis, it would technically be an abscess that forms in the soft tissues. The bony cortex can be an effective barrier to tumor growth of certain tumors. Certain tumors penetrate the cortex partially or completely, whether they're benign or malignant. Progressive endosteal erosion that is accompanied by a periosteal reaction leads to an expanded bony contour, like an aneurysmal bone cyst, or like occurs with an aneurysmal bone cyst. An aggressive lesion that penetrates the entire cortex or penetrates the Haversian canals will elevate the periosteum and lead to a periosteal reaction and an incomplete or a interrupted periosteal reaction. It is important to understand that both benign and malignant tumors can penetrate the cortical bone and form a soft tissue mass. The fact that there is a soft tissue mass does not automatically confer that the tumor is malignant. Certain benign tumors can also form a soft tissue mass. The periosteum usually remains intact around a benign soft tissue mass. This may only be detectable on a CAT scan demonstrating an eggshell rim of calcification around the periphery of the mass. The periosteum is usually destroyed by malignant tumors and does not remain intact around the soft tissue component of a malignant tumor. This is just showing you the various stages of tumor growth through the cortex. You can have a completely intact cortex. You can have an area where the tumor just pokes through or destroys a small area. You can have endosteal erosion or scalloping of the endosteal surface, and you can have a dumbbell configuration of a tumor, whether the tumor extends from inside to out or outside to in. Schematically, this is a difference between the benign and malignant tumor in terms of benign tumors with a soft tissue mass and malignant tumors with a soft tissue mass. The benign tumor will extend through the cortex, but the periosteum lays down a layer of new bone along the exterior surface of the soft tissue component of the tumor. Whereas in a malignant tumor, it penetrates either through the Haversian canals or through the cortex, and it elevates the periosteum either at the perimeter or in between all the Haversian canals, but it doesn't cross over or surround the soft tissue component on its most exterior surface. This is a large benign aggressive tumor of the pelvis. I don't think that one can really tell just by looking at this x-ray that this is a benign aggressive tumor. However, there's a hint of it based on looking at the junction of the inferior pubic ramus with the tumor. It appears to be a sharp zone of transition with this very large soft tissue component in the pelvis. There's a subtle hint of an eggshell rim of calcification around this mass and possibly some internal trabeculations, but difficult to tell completely on this x-ray. Again, the MRI, very difficult to tell, but it looks like a large soft tissue mass arising from the bone of the pelvis with large cystic areas. Here's a CAT scan, however. The CAT scan here shows a very sharp zone of transition between the normal bone here and the actual mass or tumor that developed. And around the perimeter of the tumor, there's this eggshell rim of calcification, which in my opinion was very suggestive of this being a benign process and that the periosteum was intact and reacting against the tumor. Here's a benign aggressive giant cell tumor. The tumor has grown into the soft tissues, and there's a very geographic pattern of bone destruction. The CAT scan shows you this eggshell rim of calcification around the soft tissue component of the tumor, which was difficult to discern on the plain x-ray. However, this leads you in the direction of a differential diagnosis of a benign tumor as opposed to a malignancy. Again, the MRI may or may not be helpful, but it does show a geographic lesion, and it does appear that the periosteum is intact around the perimeter of the tumor. On the other hand, here's a malignant appearing tumor. There's a permeative lesion in the distal femur. It's extended into the soft tissues, and here is our periosteal reaction, or our Codman's triangle, which is a worrisome periosteal reaction. Here's a CAT scan of the same lesion, and here's the growth of the tumor into the soft tissues with the ossification in the soft tissues, and there is no periosteal reaction around this lesion in the soft tissues. Here's the MRI of this osteosarcoma, and the periosteum is not intact around the soft tissue mass. Okay. Now we're going to go over some other important qualities about different tumors, namely different lists of different characteristics of the various tumors. It's important to note the distribution or the position of the tumor in the bone in both the transverse and longitudinal planes. So, in terms of the transverse plane, is the tumor central, eccentric, cortically based, juxtacortical, as there's a soft tissue mass? This is important because different tumors have a predilection for different areas within the actual bone. Just showing you what a tumor would look like if it grew centrally within the bone, what the term eccentric means, what the term cortically based means, what the term parosteal means, and what intracortical may mean. So now I'm just going to go over some various lists of tumors that really should just be, basically you need to memorize them and memorize where these tumors occur within the bone, and I'll also show you various examples of them. So tumors that occur along the central axis of the bone include enchondromas, fibrous dysplasia, and simple bone cysts. They usually occur centrally within the bone, not eccentrically, not cortically based, but central. This is an example of a unicameral bone cyst. You can see it's located central within the bone. This is an example of another UBC located centrally within the bone. A case of fibrous dysplasia located centrally within the bone. Another case of fibrous dysplasia where there was a pathological fracture. The fibrous dysplasia is located centrally within the bone. It has a ground glass appearance. It looked as though somebody took a pencil eraser and smudged these trabeculae, and that's the pathognomonic radiological finding for fibrous dysplasia. It has a ground glass appearance. Another example of fibrous dysplasia centrally within the bone. This is an enchondroma located centrally in the bone. How do we know it's an enchondroma? You have calcifications in a ring and arc-like manner. These are lesions that occur eccentrically in the bone. Giant cell tumor, osteosarcoma, chondrosarcoma, and chondromyxofibroma. It's a giant cell tumor. Rises in the metaphysis, spreads to the epiphysis, located eccentrically with a geographic pattern of bone destruction. Again, the osteosarcoma that I've shown multiple times arose eccentrically, extended through the Haversian canals into the soft tissues. This is what it can look like on an MRI, another example of an osteosarcoma. This is an example of a chondrosarcoma. Spread out eccentrically through the bone, form a soft tissue mass, and you have these calcifications in a ring and arc-like manner. This is a chondromyxofibroma located very eccentrically in the bone. These are lesions which arise from the cortex. Non-ossifying fibromas and osteoid osteomas tend to come from the cortex, or can involve the cortex. It's an example of a non-ossifying fibroma. Very well circumscribed lesion with an indolent border and very heavily sclerotic rim around it. This is an osteoid osteoma of the toe, the metatarsal bone. It may be difficult to identify on plain radiographs, and CAT scan is useful. You see the cortical thickening around it and a small nidus in the center. Again, MRI may or may not be useful. Often a CAT scan can be more useful than an MRI for evaluating for the presence of an osteoid osteoma. It's another osteoid osteoma of the cortex. It's arisen in the cortex. It's very irritating. It's caused a buttressing type of periosteal reaction or a continuous periosteal reaction where the cortex looks thickened. It may be difficult to see this nidus in this location, and you may need advanced imaging such as a CAT scan or an MRI. Another example of cortical thickening or buttressing with an osteoid osteoma. And here's our osteoid osteoma on a CAT scan in the cortex, causing cortical thickening or buttressing. This is an example of a Brody's abscess occurring intracortically. You can see the cortex is thickened. It can have a radiological appearance similar to an osteoid osteoma, fairly well circumscribed with thickening of the cortex. And here's an MRI of the Brody's abscess, which shows an extensive amount of surrounding edema. Here's an MRI of the Brody's abscess, which shows a sinus tract leading to the subcutaneous tissues, which is typical for a Brody's abscess as compared to an osteoid osteoma. Here are a list of some juxtacortical lesions, or surface lesions of bone. A juxtacortical chondroma, periosteal osteosarcoma or periosteal chondrosarcoma, and parosteal osteosarcoma. There's no such thing as a parosteal chondrosarcoma. This is a periosteal chondroma. You can see it resides on the surface of the bone, and you have calcifications in a ring and arc-like manner. So periosteal chondrosarcoma of the distal femur, with some periosteal scalloping and almost a Codman's triangle at the periphery here. So periosteal osteosarcoma. Periosteal osteosarcomas are cartilaginous in nature and produce bone, and in this instance they usually cause a periosteal reaction. They arise from the inner surface of the periosteum, elevate the periosteum, and can cause a hair-on end appearance from the surface of the bone as well as a Codman's triangle. This is a very worrisome finding in a patient. Again, a closer view of the periosteal periosteal osteosarcoma. Is a periosteal or a high-grade surface osteosarcoma. Again, periosteal high-grade surface osteosarcoma occurring on the surface of the bone. CAT scan of a periosteal high-grade osteosarcoma. And this is the MRI of a periosteal high-grade osteosarcoma. Most commonly occurs around the tibia. The dark areas probably represent bone formation. And this is an example of a parosteal osteosarcoma occurring on the posterior distal femur, the most common location, arising on the surface of the bone, which is heavily mineralized and fluffy and cloud-like density, causing demonstrating ossification. Here's a CAT scan of the same tumor. Here's an osteochondroma. There's corticomedullary continuity between the femur and the osteochondroma. The cortices are continuous as well as the medullary canal. And then here is the cartilaginous cap where you see flocculent calcification. Again, arising eccentrically from the bone. Or rising from the surface of the bone, that is, not eccentrically from the surface. Here's a CAT scan of the same tumor. You can demonstrate the corticomedullary continuity in this location. This is a surface osteoma. Basically, it looks like the bone is just thickened in this area. It's important to evaluate patients' gastrointestinal tracts for polyps if they are diagnosed with an osteoma. Myositis ossificans can occur on the surface of the bone. And when you do a CAT scan of myositis ossificans, if it's mature, usually the outer portion of the myositis ossificans looks like it's cortical bone, and the inner aspect looks more like medullary bone. It's trying to replicate a normal bone where there's a zonal phenomenon of outer cortical bone and inner medullary type of bone, or a central lucency and more developed or more mature bone around the perimeter. Melorhiastosis consists of undulated thickening of the cortex or undulated deposition of bone on the surface of the bone, and it has an appearance similar to candle wax drippings. You can also get intra-articular masses that can be symptomatic. You should always evaluate the position of the lesion in the longitudinal plane of the bone, whether it's in the epiphysis, metaphysis, or diaphysis, because there's certain tumors that occur in certain locations. In terms of epiphyseal lesions in adults, the differential is clear cell chondrosarcoma, metastasis myeloma lymphoma, intraosseous lipoma, and intraosseous ganglion. Intraosseous lipoma usually occurs in the calcaneus, which is an epiphyseal equivalent. In children, this is a differential for epiphyseal lesions: chondroblastoma, osteomyelitis, osteoid-osteoma, Enchondroma, although it's very rare. Usually these are more metaphyseal, and eosinophilic granuloma. This is a list of metaphyseal lesions: giant cell tumor, which extends to the epiphysis, non-ossifying fibroma, chondromyxofibroma, simple bone cyst, osteochondroma, Brody's abscess, osteosarcoma, chondrosarcoma, MFH, and fibrosarcoma. MFH nowadays is called undifferentiated pleomorphic sarcoma. Here's a list of diaphyseal lesions, or lesions that tend to occur in the diaphysis of bones. Ewing sarcoma, non-ossifying fibroma, really tends to occur metadiaphyseal. Simple bone cysts or unicameral bone cysts, aneurysmal bone cysts, enchondromas, osteoblastomas, fibrous dysplasia, adamantinoma, and osteofibrous dysplasia. These are considered epiphyseal equivalent areas: the subchondral regions of the acetabulum and the scapula, the tarsal bones, and the calcaneus and the talus. These areas tend to be prone to form the same types of tumors as the list of tumors in the epiphysis, namely chondroblastoma, clear cell chondrosarcoma, e.g. intraosseous lipoma, osteomyelitis, e.g. means eosinophilic granuloma, osteoid-osteoma, osteoblastoma, and Mets myeloma, lymphoma, and intraosseous ganglion. Some important points to remember: tumors usually do not cross the growth plate. Rarely they do, but if you see a lesion that crosses the growth plate, you have to think of an infection. This is showing you schematically centrally located lesions: unicameral bone cyst, enchondroma, fibrous dysplasia. Eccentrically located lesions: giant cell tumor, fibrous cortical defect, which is essentially a small non-ossifying fibroma, NOF or non-ossifying fibroma. ABCs are eccentrically located: chondromyxofibromas, osteomas, all tend to be eccentrically located. Here's our schematic for periosteal tumors, or surface tumors of bone, or also called juxtacortical tumors: periosteal osteoblastoma, periosteal chondroma, periosteal osteoma, periosteal osteosarcoma, periosteal osteosarcoma, and periosteal chondrosarcoma. There is no periosteal chondrosarcoma. Here is a list of cortically based tumors demonstrated schematically. Osteoid-osteoma, osteoblastoma, both can occur intracortically. Actually, osteoblastoma can really occur any place, any location. 50% of them occur in the posterior elements of the spine. in the long bones, they could really occur any place in any location. A cortical abscess or a cortical or a Brody's abscess, cortical metastasis, hemangiomatosis can involve the cortex. Osteofibrous dysplasia notoriously involves the cortex of the tibia, and intracortical osteosarcoma, of which there are probably only about 50 reported cases ever. This is showing you a schematic of a skeletally immature patient and some of the most common tumors that occur in a skeletally immature patient. Notice the open growth plate. This is the epiphysis. Chondroblastoma typically occurs in the epiphysis in skeletally immature patients. Osteosarcoma occurs very eccentrically in the metaphyseal area. Simple bone cysts centrally, distal to the growth plate. Osteochondromas from the periphery of the bone, the surface lesion of bone from the area around the growth plate. Fibrous cortical defect, aneurysmal bone cyst, chondromyxofibroma, enchondromas which occur centrally, non-ossifying fibromas which arise from the cortex, also extend intraosseously, fibrous dysplasia that occurs centrally, osteofibrous dysplasia which actually usually involves the cortex of the bone. Actually, osteofibrous dysplasia in this location should be pointing to this little black area, which usually involves the cortex. And Ewing sarcoma usually occurs more centrally in the metaphysis, in the diaphysis of the bone in a permeative manner. So this would represent Ewing sarcoma, and this would represent the osteofibrous dysplasia. This is an osteoid osteoma that is intracortical and a periosteal chondroma. This is schematic for a skeletally mature patient. You can have giant cell tumors and malignant fibrous histiocytoma or high-grade bone sarcomas arise eccentrically from the metaphysis. Intraosseous ganglion in the epiphysis. Clear cell chondrosarcoma can involve the epiphysis. Note the growth plate is closed. Myeloma, which usually occurs in the medullary canal, more proximally in the metaphyseal diaphyseal area. Cortical metastases, fibrosarcoma, adamantinoma, other types of metastases, and lymphoma. These are common spine tumors with their location. Okay, your malignant types of spine tumors, which usually affect the anterior body of the spine, of the vertebral body, include lymphoma, Hodgkin's disease, myeloma, Ewing's, which is relatively rare, osteosarcoma and chondrosarcoma, which are rare, and various metastases. Exceptions include hemangiomas, which usually involve the vertebral bodies, and these are benign. Langerhans cell histiocytosis, which can involve the vertebral body, it's benign and results in a vertebral plana, and fibrous dysplasia, which can involve the vertebral body. These are benign tumors which usually involve the posterior elements of the spine. Osteoblastoma, osteoid osteoma, aneurysmal bone cyst, osteochondroma, and chondromyxofibroma. So usually these arise from the posterior elements. And metastases can also involve the posterior elements of the spine, but more commonly affect the anterior elements. Hematopoietic marrow has a predilection for sites with red marrow, rich sinusoidal. Myeloma has a predilection for hematopoietic marrow, predilection for sites with red marrow, rich sinusoidal vasculature. The axial skeleton in the adult is a very common site for metastatic disease, myeloma, Ewing sarcoma, and histiocytic lymphoma. Areas of rapid growth are sites of origins for primary bone tumors, namely your distal femur, your proximal tibia, and your proximal humerus. And hence these are the most common locations for osteosarcoma and Ewing sarcoma. And this is going over the vertebrae in adults. Vertebral lesions in adults, this is the differential. Skeletal mets, myeloma, hemangioma, lymphoma, and osteomyelitis. And in children, eosinophilic granuloma, aneurysmal bone cysts, osteoblastoma, osteoid osteoma, lymphoma, leukemia, and osteomyelitis. Of note, we didn't mention this previously, but an osteochondroma can affect the posterior elements of the spine. Differential of a sacral tumor, chordoma, myeloma, plasmacytoma, giant cell tumor, METs, simple cysts, and neurogenic tumors or cysts. Chordoma usually occurs centrally. Myeloma may occur centrally. Giant cell tumor usually occurs eccentrically. The sacrum can be a site for an aneurysmal bone cyst in children. These are the most common tumors to affect the ribs: metastases, fibrous dysplasia, and enchondroma. Most common tumors to affect the metacarpals and phalanges: giant cell tumor, giant cell reparative granuloma, sarcoidosis, aneurysmal bone cyst, fibrous dysplasia, and enchondroma. Enchondromas actually are more likely to affect phalanges as opposed to metacarpals. Your terminal phalanges, the differential of lesions in that location include inclusion cysts, glomus tumors, and metastatic lung cancer. Okay, here's some tumors with predilections for certain sites. Osteoid osteoma tends to affect the femur and tibia most commonly. Most common site is the neck of the femur and usually located centrally in the neck. Chondroblastoma, most common in the tibia and in the epiphysis, and usually eccentrically in the epiphysis. Chordoma tends to affect the sacrum, C2, and the clivus. Usually occurs in the posterior aspect of the clivus or the distal end of the sacrum, and it arises centrally. Periosteal osteosarcoma most commonly arises in the femur along the posterior aspect of the distal end, and usually very eccentric. Osteofibrous dysplasia almost always arises from the tibia along its anterior aspect, and it's cortically based. Adamantinoma almost exclusively arises in the tibia along its anterior aspect. It may be osteofibrous dysplasia, may be a precursor for adamantinoma, and arises in the cortex. Giant cell tumor tends to, the most common locations are the proximal, the distal femur, that is, proximal tibia, and the radius. Arises in the articular end of the bone very eccentrically. Aneurysmal bone cyst arises most commonly from the tibia and the humerus, arises from the metaphysis eccentrically. Simple bone cyst usually arises from the humerus and the femur, arises from the metaphysis, and arises centrally. I'm sorry, there are a few mistakes in this diagram, but usually arises centrally in the bone. Chondromyxofibroma most commonly arises from the tibia and from the metaphysis, and is usually located very eccentrically within the bone. We're going to go through some unknown examples. This is a patient who presented with left shoulder pain. You can see a lytic lesion that's very well circumscribed. There's some mineralization with the lesion identified on the CAT scan. The patient is skeletally mature. It's a epiphyseal lesion with a geographic pattern of bone destruction, so it's probably benign. It's eccentric. There's calcifications, and it has a sclerotic 1A, 1B margin. It's a chondroblastoma. Here's unknown number 2. This is a vertebral body. The lesion is located right here. It does have some calcifications within it. It's a spine lesion, the posterior elements, geographic pattern of bone destruction, probably benign. Internal mineralization indicative of bone-producing or cartilage-producing tumor. This is an osteoblastoma. 50% of osteoblastomas occur in the posterior elements of the spine. And then number 3, here's the X-ray, and here's the CAT scan. It's a small cortical lesion. There's a geographic pattern of bone destruction. There's extensive surrounding sclerosis. There's a buttressing periosteal reaction, probably indicating that it's benign. And there's some subtle internal mineralization identified on the CAT scan. This is an osteoid osteoma. It's unknown number 4. This is an X-plane radiograph. Notice the lesion in the center of the bone, calcifications. This is a central diaphyseal lesion. There's no periosteal reaction, no cortical destruction, and there's calcifications in a ring and arc-like manner. It's an Enchondroma. And you can see here the calcifications. If you look very closely, they occur in a ring and arc-like manner. Unknown number 5. This is a metaphyseal eccentric lesion. It's permeative, indicating that it's probably malignant. There's cortical destruction. There's calcifications in a ring and arc-like manner up over in this location here, indicative of a cartilage tumor. Dedifferentiated chondrosarcoma. So you can see the low-grade indolent or more low-grade indolent appearing cartilage tumor in this location with an area of lysis next to it that's highly destructive, consistent with a high-grade spindle cell sarcoma. It's unknown number 6. This is the X radiograph. Notice this area. There's a permeative pattern of bone destruction. The lesion is diaphyseal. There's cortical penetration. There's hair-on-end periosteal reaction, indicating it's probably malignant. There's no internal mineralization, so it's probably not a bone or cartilage-producing tumor, and it's malignant appearing. It's a Ewing sarcoma. Hair-on-end periosteal reaction, permeative lesion within the bone. Perhaps a subtle Codman's triangle in this location and over in this location. Unknown number 7. This is the proximal humerus or shoulder girdle. This is a permeative and moth-eaten lesion. So metaphyseal / central lesion, permeative pattern of bone destruction, which indicates it's probably malignant. There's no internal mineralization, so it's probably not a cartilage or bone-producing tumor since there's no visible matrix, although you can't be 100% sure without a CAT scan. There's no periosteal reaction, and it's an aggressive malignant-appearing lesion in a skeletally mature individual. Fibrosarcoma of bone. Unknown number 8. This is the elbow, this is the humerus, and here's the lesion. It's a central lesion, geographic pattern of bone destruction, so it's benign appearing. It's located in the metadiaphysis. The bone is expanded, there's a benign periosteal reaction, meaning when the bone is expanded, that is the equivalent of a benign appearing periosteal reaction. There's no internal mineralization, so it's probably not cartilaginous or bone producing. And there's a ground glass appearance. It's fibrous dysplasia. It looks like somebody took an eraser and smudged all the trabeculae within the lesion. Unknown number 9. It's a radiograph. Here's the lesion. This is the proximal tibia. Eccentric lesion in the proximal tibia. It arises in the metaphysis and extends into the epiphysis. There's no internal mineralization. The cortex is thinned and slightly expanded. There's a thin, incomplete sclerotic margin, a type 1B, and it's benign appearing. It's a geographic pattern of bone destruction. It's in a skeletally mature adult. This is a giant cell tumor of bone. Unknown number 10. Plain radiograph of a distal femur. This is a metadiaphyseal lesion. It's mouthy and impermeative, meaning that it's malignant appearing. There's no internal mineralization. There's cortical destruction, but no periosteal reaction. Malignant fibrous histiocytoma of bone. Unknown number 11. This is a skeletally immature patient. This is the shoulder. There's a pathological fracture in this location, and here is the lesion. The lesion is located centrally, rises in the metaphysis. It's multiloculated, geographic. The bone is expanded slightly. Patient skeletally immature. There's no mineralization, and it's benign appearing. The answer is unicameral bone cyst. Unknown number 12. This is the distal tibia, a very eccentric lesion, possibly an internal trabeculation. Eccentric cortical lesion, metaphyseal, geographic pattern of bone destruction. It's well circumscribed, type 1A margin, indicating it's probably indolent. There's no internal mineralization. The bone has an expanded contour, and it's benign appearing. The answer is a non-ossifying fibroma. Unknown number 13. This is a digit. Geographic central lesion in the phalange. Lobular growth contour with endosteal scalloping. Cartilage grows in a lobular manner. There are punctate calcifications if you look at the arrows, indicating that it's probably cartilaginous, and it appears benign. Diagnosis is Enchondroma. Unknown number 14. Occurring in the tibia in a skeletally immature individual. It's located in the cortex. It's a cortically based lesion, geographic, and located in the tibia. There's an extensive sclerotic margin, and there's tibial bowing. Osteofibrous dysplasia, which may be a precursor to adamantinoma at an older age group. Unknown number 15, this is a distal femur, and here's the lesion arising from the distal femur. It's a skeletally immature patient. Lesion is permeative / moth-eaten, giving it a malignant appearance. It's eccentric and metaphyseal. There's ossification present within the neoplasm. Codman's triangle. Patient skeletally immature, but it spares the growth plate. There's cortical destruction, and it appears malignant, and it's producing osteoid, or a bone formation. This is an osteosarcoma. I want to thank you all for listening to this video. I hope that it's educational. Please see my website at www.tumorsurgery.org for more information about musculoskeletal tumors. And please feel free to contact me with any questions. Thank you very much.